Então, bom dia a todos. Vamos, então, dar início ao nosso segundo dia do 9º Congresso Sul-Brasileiro de Nefrologia, um evento compartilhado pela Sociedade Paranaense de Nefrologia, pela Sociedade Gaúcha e pela Catarinense. É um prazer abrir essa sessão de hoje como moderador. Sejam todos muito bem-vindos. E vamos voltar a um tema que começamos a discutir ontem, que é a esclerose tuberosa, onde teremos a honrosa presença do professor John Bissler, do Tennessee, Estados Unidos, onde ele é o diretor médico da nefrologia, professor de pediatria da Universidade de Tennessee, além de ser o diretor do TUBEROUS Sclerose Center of Excellence, e uma pessoa assim, de uma importância fundamental no desenvolvimento do conhecimento da esclerose tuberosa e no desenvolvimento de abordagem terapêutica e de monitoramento desses pacientes. Então, vamos iniciar com a aula do professor Bissler. É uma aula que está gravada e ele vai estar presente online após a apresentação para que possamos discutir um pouco sobre esclerose tuberosa e dúvidas que, porventura, tenhamos, não só na parte científica, mas na parte prática do dia a dia também. Então, acho que podemos iniciar com o vídeo da aula. Obrigado.
Good morning. My name is Dr. John Bissler. I'm the Federal Express Chair of Excellence at the University of Tennessee. I'm also the Director of Nephrology at St. Jude Children's Research Hospital, the Division Chief of Nephrology at Le Bonheur Children's Hospital, and for the purposes of this talk, I'm also the Director of the Tuberous Sclerosis Complex Center of Excellence. And I am very privileged and honored to be able to talk to you about the renal manifestations of TSC, specifically about the pathogenesis and therapy. And to do this talk, I'm going to stop my video so that I'm not so distracting. I have multiple objectives today. First, I want to talk about the angiomyolipomas associated with tuberous sclerosis. Specifically, I talk about how they arise, talk about the classical lipid-rich angiomyolipomas, and also talk a little bit about the fat-poor lesions, and then discuss the complications of angiomyolipomas, why they're an issue and why we should care. I also want to talk about the renal cystic disease associated with tuberous sclerosis. We'll talk about the 5 different phenotypes of cystic disease, about the more interesting pathobiology, and the complications of renal cystic disease, specifically about the proteinuria and hypertension. We'll also talk a little bit about the renal cell carcinoma associated with TS, and then we'll talk about the treatment of the disease manifestations. Let's start first with angiomyolipomas. To start with, I'm going to show a cartoon where it shows a signaling pathway controlling cell growth through protein synthesis. The red proteins stop or slow down the process. The green proteins stimulate them. And the mTOR, or mechanistic target of rapamycin, sort of is the integrator of this signaling to control protein synthesis and therefore control cell growth and proliferation, the formation of blood vessels, the control of the cell metabolism, as well as the cell behavior, orientation, and migration. The TSC1 protein, also called hemartin, it comes from a gene on chromosome 9. And here I've depicted the maternal chromosome in pink and the blue or paternal chromosome. And the patient gets a TSC1 protein or hemartin from each chromosome. The TSC2 gene or tuberin protein comes from chromosome 16, immediately adjacent to the PKD1 gene. And in this cartoon, I've depicted the paternal chromosome as not producing the TSC protein. What's thought to happen in the angiomyolipoma is that the TSC2 gene that's functional is lost. When that happens, the protein is not made. When the protein's not made, the TSC1 protein doesn't go where it should or doesn't do what it should. And so this pathway is driven forward and it's uncontrolled. Using immunostains, it would appear that angiomyolipomas may come from a blood vessel cell. And here I have an arteriole within an angiomyolipoma. Here you can see the lipid-containing cells. Basically, after the xylene treatment, there are these holes in this H&E stain, hematoxylin and niacin stain. The red cells are in the center. The endothelial cells look fine. The muscle, the smooth muscle, vascular smooth muscle is quite strange. In some areas, they're very thin, some areas thick. And then the connective tissue, the tunica adventitia, is really disorganized. I'm going to draw a cartoon to make this more understandable. Here is a capillary, and outside the capillary sits a pericyte labeled with a P. And the arrows depict the fluid that has transutated across the endothelium and tissue underneath the pericyte. So I'm going to depict it in this fashion. In angiomyolipomas, we think that the TSC, the functional TSC gene, becomes disabled. Now, pericytes are interesting. They can be beyond controlling what every other cell does in the blood vessel. They also can differentiate into smooth muscle cells, into fat cells, into a huge number of different cell types. And so the pericyte doesn't have to stay a pericyte. It can begin this pathway towards some other formation, other cell type. When it does that, it doesn't need to stay in contact with the vessel. And this is sort of a feature known to occur in angiomyolipomas, the sort of poster child of a perivascular endothelial cell tumor, or PEComa. We've known since the 40s that angiomyolipomas will metastasize to lymph nodes, and we hypothesize that this might be involved in the spreading of such unusual cells to the lung, driving the disease in TS called lymphangioliomyomatosis. Well, let's talk a little bit more about these angiomyolipomas. We talked yesterday about CT scan. You can use CT to image, and it basically functions on tissue densitometry. There's the downside of the recurrent radiation exposures and contrast exposures for patient, making it less than an ideal approach. Ultrasound is used in some places that can't do better imaging, and it works by tissue density, causing reflection of the signal back, and it helps you understand what you're looking at. A problem with TS is 30% of patients will have fat-poor components in their angiomyolipomas, and the tissue density is identical to that, to kidney. So basically what I'm telling you is that the fat-poor components are invisible to ultrasound. And then MRI, and it can be done at the same time as doing brain MRIs, especially in children, and it detects all the lesions that are missed by CT and ultrasound, and it's really the first choice for imaging, as we talked about yesterday. But what's the problem with having an angiomyolipoma? So what? Well, larger angiomyolipomas are associated with abnormalities in these blood vessels, aneurysms. And here's an example in the same patient. There's a coronal and an axial section for you with brilliant yellow arrows to show you the aneurysm that's popped off the renal artery. Breaking of this aneurysm would lead to significant hemorrhage, and it would be life-threatening. So the point of this is that angiomyolipomas have a life-threatening risk, immediate life-threatening risk with aneurysms, and it can also damage renal function to the point where you have chronic kidney disease. In fact, it's interesting. patients with tuberous sclerosis have significantly worse chronic kidney disease than their age-matched controls. In this study, we looked at CKD stages 3 to 5 in TSC patients or their UK general population controls, and their renal function is similar, patients' renal function is similar to the general population 30 years down the pike. So the point here is that TSC patients really do have a significantly decreased renal function, in part because of angiomyolipomas and their treatments, embolizations, nephrectomies, as well as the cystic disease. And so all of these aspects really drive the need to have a way to approach improving renal function. Now, angiomyolipomas respond to mTOR inhibitors. The studies published in 2013 published the registration trial for mTOR inhibitors like everolimus to treat these patients. And on your left is a waterfall plot that shows you that 97% of the patients had a reduction of tumor volume. What's interesting about this reduction, this is just the best response at any time point, but on your right is the reduction of volume over time. And the gray is a 30% reduction and the black is a 50% reduction. And what you see is about the same number of patients respond with 30 plus 50, but the amount who continue to have a 30% reduction decreases while more develop a 50% reduction. The point is that over time, the lesions continue to shrink. That's a very valuable feature. So that's all known, that angiomyolipomas in TS respond to mTOR inhibitors. What about cystic disease? And here I have just an example of a normal MRI contrasted with one of the 5 phenotypes, the polycystic variety. I told you yesterday that the 5 varieties of renal cystic disease in TS are broken up based on where the cysts are located, their distribution, their size, and their number. And we talked about cortical cystic disease, micro and multicystic disease, focal and polycystic disease. I won't spend a lot of time on that today, but I do want to contrast the pathophysiology and the pathogenesis of cystic disease with that of angiomyolipomas. To help clarify the pathobiology, I have staining for just H&E staining and for the proteins hamartin and tuberin in 3 columns. And on the top is angiomyolipomas, and on the bottom is cystic disease. And the black arrows on the top depict the angiomyolipoma in the H&E, and you can see that it stains brilliantly for hamartin, and in this patient with a TSC2 mutation, tuberin is not expressed in that lesion. That makes pretty good sense. Please contrast this odd finding. The cystic disease, here the black arrow shows a microscopic cyst, but this cystic disease continues to express hamartin and tuberin in almost all the cells. Not all of them, but almost all of them. Well, that's just puzzling as can be. To understand this better, I chose to develop a mouse model. Now, since the principal cells, the collecting duct principal cell, is involved in cystic disease and autosomal dominant polycystic kidney disease, I used the promoter for aquaporin 2 to drive Cre recombinase, and then used floxed TSC1 or TSC2 and bred this into the mice. And I also bred this system onto a mouse model called confetti. Now, this confetti model has multiple fluorescent proteins that are disabled because there's an insertion that disrupts the gene. But if Cre is expressed, it will reactivate so that you can see color. And I'm showing you just some of these. We've published this, so it's old news. The yellow arrows in each of these shows recombination where Cree has reactivated the fluorescent proteins. But what's more interesting and more important is the white arrows. The white arrows depict cystic structures that don't express any fluorescent protein. More to the point is these non-fluorescent cells still express both hamartin and tuberin in the mouse model. And in fact, we've gone on to further characterize these, and these are genetically intact type A intercalated cells. So the principal cell is driving the type A intercalated cell into the mutant phenotype. Well, how does that work? How does it work? How do the mutant cells get the healthy cells to participate in the mutant phenotype? And to the best of our ability, we believe that they do this by releasing a lipid bilayer structure called an extracellular vesicle. This contains messenger RNA, microRNA, non-coding RNA, DNA, metabolites, other different proteins. And this is basically a structure that can bind and does home back to kidney, bind to the intercalated cells to alter their programming to drive the mutant phenotype. So here's a cartoon to try and explain this better. The blue principal cells that express primary cilia release these extracellular vesicles that are taken up by the intercalated cells, which do not express a primary cilia, reprogram them to behave in such a way as to drive proliferation and formation of a cyst. Well, that's pretty interesting from a pathobiologic standpoint, but what do the cysts do? How do they participate in making the patient sick? And so I've drawn a cartoon of a nephron, and I want to talk about the collecting duct here, because the human cystic disease also is made up of type A intercalated cells. So I'm going to take a portion of this nephron, of the collecting duct, here depicted in a much more rough draft model. And you think about it, if mutant cells start to grow and they're releasing these extracellular vesicles, the ability for the extracellular vesicles to interact with the normal cells is increased as the abnormal cells begin to proliferate, because flow through that region is proportional to the fourth power of the radius. What I'm saying is little changes slow the transit, so there's more time for these EVs to interact instead of just being washed downstream immediately. And so this is sort of this feedback system. The bigger it gets, the more it interacts, and it continues to grow. And in fact, they continue to grow until they detach from the collecting duct. While they're still attached, you can, if you turn off the mTOR activity, they can remodel. Once they've detached, it's a different kind of disease. What's important about the cysts is their mass effect. If you bivalve the kidney and take a look at this, you can see how the cystic disease would impact the vasculature. Specifically, not pushing against an arteriole or an artery, but the vasa recta, the capillary network, and the venous high flow, low pressure venous structures. So if you look at this nephron with the vasculature and we just take the glomerulus, as the cyst grows, you can see where it would increase the resistance, therefore increasing the intraglomerular pressure, increasing the filtered fraction, so you get hyperfiltration, driving the proteinuria. In addition, you get a slowing of the blood flow and a release of renin and driving the angiotensin-renin-aldosterone system to cause the hypertension. Well, these two features, the hypertension and proteinuria, we figured would drive and continue to accelerate the loss of kidney function in our patients. So we began a trial of a kind of a different way to approach this disease process. This paper is almost done and will be submitted before the beginning of the year, but we used a robotic approach to unroof the cyst to allow them to drain in the retroperitoneal space, the fluid be reabsorbed and filtered again, and then place the patient on mTOR inhibitors to stop the small cysts from growing. On your left is a patient of about 7 years old with the polycystic variety, and she had an interesting pattern. She had very large cysts, but also had significant elements of pretty normal looking kidney. As you can see, the upper pole of that left kidney looks really good. The right kidney is pretty squished. So we disrupted these cysts and put the patient on an mTOR inhibitor. And then 17 years later, the scan on your right is the same patient at 17, so a decade later, and you see that her cystic disease is still pretty minor. And the rest of the disease looks really good because we've used an mTOR inhibitor to suppress that disease. The hypertension in these patients also improved. These are the first 5 patients, and this is blood pressure medication at 6 and 9 months. 6 is black and gray is 9 months. And this is the percent of reduction. And so you can see each of these 5 patients had a reduction in the requirement that seemed persistent for blood pressure medication. Beyond that, they also had a reduction in their microalbuminuria. So we're affecting the hyperfiltration by disrupting the large cystic elements, and we're improving their outcome in this fashion. In these first few patients, we now have more than a dozen patients, and this seems to be holding true. That the mTOR inhibitors are really effective. We proved that they were effective in reducing angiomyolipoma volume and actually aneurysm formation. If a patient's on an mTOR inhibitor, their likelihood of having a hemorrhage is substantially reduced. But what about the cystic disease? And so here's an adult patient with significant cortical cystic disease, really almost microcystic disease, and angiomyolipomas. And here, 12 months later, you see, let's start with the angiomyolipomas. The upper pole of the right kidney is a nice sized lesion that's 12 months later is significantly reduced. On the left kidney in the lower medial pole, there's one that's gone, and it's not in any of the slices that we have. In addition, just the eyeball alone can show you that there's a significant suppression of the small cystic disease by a reduction of the white water signal from this T2 weighted imaging. So the cystic disease likewise improved. This small cystic disease can also be improved with focal cystic disease. Here's a wonderful example of significant left kidney involvement in focal cystic disease. There was also involvement in the right kidney, but less so, but not in this plane. In the referral center, they recommended a left nephrectomy and a multiple partial right nephrectomy. And the family was not interested in this approach because they figured that the kidney function would be so badly affected. And so we put the child on an mTOR inhibitor. On your left is 6 months of age. On your right is 18 months of age. And what you can appreciate is a profound reduction of the cystic disease. There's still some cortical cystic disease, but there's a return of the cortical medullary differentiation that you can see. and there's some small cyst in the cortex, but not much. So this is a wonderful improvement for this patient. Now, this isn't to say that renal cancer doesn't occur in TS. There is a lesion that definitely looks like clear cell renal cell carcinoma, as well as papillary renal cell, that occurs in TS. It's just extremely rare. It has the right markers. Of course, you're looking at tumors that come from kidney tissue, so they will likely have these markers. The other aspect that's interesting to think about is that these tumors are driven by they look the same, but they're driven by a different genetic driver. In the general population, most clear cells are associated with a mutation in the VHL, von Hippel-Lindau 1 gene. In the older population, in children and young adults, it's a translocation gene abnormality that is not also in the TSC population. So is it just a similar appearance or a similar disease? The behavior of the clear cell, because they're so rare, it's hard to truly know, but it looks like their metastatic potential in the TS patient is reduced. And it looks like they may not grow in the same fashion, but we do think they occur. So it does raise an interesting aspect. Is there something about a link between the cystic disease and the renal cell? And is it possible that extracellular vesicles are involved in both of these processes? And if we could suppress the EVs, I will tell you, in experimental systems, if you treat cells with a disruption, for example, in TSC2, with an mTOR inhibitor, they drop by at least 50% their EV production back into a normal cell behavior, and the contents of the EVs change. So maybe there's something about this that may be helpful well beyond tuberous sclerosis. But I'm coming to the close of my time and want to be able to have time for questions, and so I'll give you some conclusions. From the angiomyolipoma standpoint, they more clearly exhibit a loss of heterozygosity at the involved TSC locus, and they can be treated with mTOR inhibitors. Even if they only just stop growing, you suppress aneurysm formation, and this is a positive thing. And you also end up treating other aspects that you may not intended. For example, the skin improves, you may be preventing the lung disease. There's a lot of possibilities. When it comes to the renal cystic disease, we talked about the fact that maybe they're mediated by EVs, but they also, the small ones, can be treated with mTOR inhibitors, as long as they can be drained by some connection with the collecting duct. And then we also talked about the fact that TSC-associated renal cell carcinoma is extremely rare, but maybe it's a different kind of disease than the VHL gene or the translocation-associated RCCs, and that time will have to tell. We'll need time to begin to sort that out. At this point, I ought to stop because I would love to hear your comments and questions, and I'm happy to answer any questions that you may have. Thank you again for your kind attention to this talk.
Thank you, John, for this outstanding talk. We learned a lot from you today and yesterday. And
recording in progress.
I think I also have to say I'm sorry for making you wake up earlier today. I think you are 2 hours before us, isn't it?
So, oh, it's all right. I'm up early anyway.
Thank you so much for being with us today. So the session now is open for question. I don't know if anyone from the audience wants to take advantage of this moment to make a question to Professor Bissler. I have at least one question. I have many questions, but I can make one at this moment. We learned from you today that the size of the angiomyolipoma is a criteria for starting mTOR inhibitor therapy in TSC patients. But they also have a good effect on preventing the increase of the cysts as well. But if the cysts are still small, so do we have any criteria regarding the size of the cysts? And there is any relationship between the size of the cysts and the size of the angiomyolipoma? I mean, perhaps we should start mTOR inhibitor therapy before angiomyolipomas are higher than 3 centimeters because the cysts are still small. So which criteria should guide us to start the therapy, the specific therapy?
That is a fabulous question. And honestly, while 3 centimeters is used in adults, in pediatrics, if they have lesions that are smaller, but they're definitely growing, then that to me, the growth velocity, that they're growing and there's multiple, then I definitely treat. If there's only one and it's growing very slowly, then I may watch. The cystic component is important. If they have a good burden of cortical cysts, for example, or a good burden of small cysts, small being in the millimeter range, less than a couple of centimeters, they still have the potential to respond. And so, just as you say, if the child has a heavy burden of cystic disease and angiomyolipomas that are small but growing, I don't wait till 3 centimeters. I go ahead and treat, because as you can see from the patients that I showed you, it can be extremely effective. And you know, I haven't done it long enough. I mean, cystic disease like this takes, you know, 30 to 50 years to show the real reduction in kidney function, perhaps. But with the improvement that I have seen, it's quite clear that the renal longevity will be improved. So it's really the extent of disease the patient has, both cystic and angiomyolipoma, and the rate of growth for the angiomyolipomas.
Okay, thank you. I also have a silly question. What about water intake? Should we stimulate to increase water intake in these patients as we do to ADPKD patients? Does the cysts respond to this therapy?
This is not a silly question. I think it's a very good idea, and I do this. I really push water intake. First, it has its beneficial effects, while it's controversial, beneficial effects on the CKD development or rate of change. But I also think that there is something to that. Now, it's complicated. I don't want to make it sound like that the two diseases are identical, because I don't think that's true. The type A intercalated cells actually do not express the V2 receptor, for example, that tolvaptan works on. However, I think there's communication between the principal cells and intercalated cells, and I think it's important. I haven't shown it in animal models yet, working on it, working on the experiments, to see if you can suppress or slow cyst growth with improved water intake. But clinically, I do recommend it. First, it doesn't hurt them. Second, I believe it helps, and it improves the CKD outcome. So all of those are good reasons to do that.
Good morning, Dr. Bissler. It's Roger Molinari.
Good morning.
Thank you so much for your talk this morning. And I will thank you for our intercession yesterday also. And I think it was a brilliant play. And now with your interventions, our awareness in TSC has grown. We hope your early start on a Saturday was worth it for sure.
You don't feel bad. I was up at 5 o'clock walking my dog. That's just the
too bad for him. You had to stop the walk. Yeah, you can go back now.
There was some complaints about it.
Yeah, I suppose. But I wish to thank you, and we wish you a nice Saturday and a wonderful weekend. Thank you so much, and see you in Brazil again.
Have a fabulous meeting, and thank you so much for the invitation. I'm very honored.
Bye-bye. See ya.
All right. Bye-bye.
Queria agradecer a todos os colegas, anunciar que nós teremos a premiação dos nossos trabalhos, tanto do tema livre, escolhido pela comissão científica, quanto do pôster, mais tarde hoje, um pouco antes do nosso happy hour de despedida. Nós teremos a premiação, uma oferta do Congresso, eu ainda não tenho os nomes, mas a comissão científica já finalizou a sua análise e eu tenho certeza que vocês concordarão conosco. Desejo um bom congresso. Auditório 1 já está preparado. Quem vai ficar aqui, sejam bem-vindos e aproveitem o dia. Muito obrigado.